that is then life-threatening.
So are you saying that the lungs are the critical part of the body which get affected? And how inevitable is that? What is the proportion of a person getting lung involvement by this
Well,
virus?
it's hard to say that, but those whose immunity is low by overwork, by tiredness, by lack of good diet, age, advanced age, patients having comorbidities like hypertension, heart problems, asthma. We have seen patients with asthma are really badly infected with this virus, and it's very hard for them to come out of this. And when they go into respiratory failure, for which I'm going to talk you about later on, once they go into that, then it's very difficult for them to come out. We have seen the mortality rate is literally up to 60, 70%.
And what are the factors which push the virus to involve lungs? Are there any particular proportion of people, particular category of people who get more involvement of lung than others?
Well, as I said, I mean, this is elderly population which is more affected, but we have got people as young as 5 years old. A child as young as 5 years old has died, I think, 2 days ago in UK. Plus, a patient of we've got two 35 years old males in our intensive care unit who are very sick, but luckily they have shown improvement, so they are getting better. So basically, it's elderly population, patients with having lots of comorbidity and low immunity are the ones who are at risk.
So anybody who's taking steroids on immunosuppressants, they would be the victims, and the elderly population. What about smokers?
Yes, smokers, if they get it, then it's very difficult for them to come out of it. If the virus goes down into their lungs, then it can play havoc, and the smokers and asthmatic patients are the worst affected.
That's a very important point that people who are smokers, who are asthmatics, they are at particular risk to getting the serious effects of corona implications. So taking it further, Dr. Taimur Mirza, we want to know that when corona affects lungs, is that parenchymal involvement different type of pneumonia or a standard pneumonia?
It is a viral pneumonia. The findings are the same, but it is somehow very resistive to treatment. At the moment, we don't have any treatment, although people in America are now trying anti-malarials and antivirals towards it, but it's very unpredictable. There's no treatment as such, but the lung parenchyma is affected. All the alveoli, they get filled up with the inflammatory fluid, and there is a cytokine storm which takes over IL-6. It is called interleukin 6, which takes over and then causes havoc in the body. It causes sepsis, then multi-organ failure, and then death.
So
So
this
if
ARDS, this ARDS, is that a typical white lung syndrome?
it is typical white lung syndrome, as you see on the chest X-ray, when it appears and the cavities are filled with water. It's typical ground glass appearance on the lungs, chest X-ray, and you see the infiltrates, classical infiltrates inside the lungs.
So we welcome Dr. Hafiz. Dr. Hafizur Rahman is again a consultant in institutes like Dr. Taimur Mirza, very senior and very experienced. Welcome, Dr. Hafiz Rana. Dr. Hafiz,
Thank you very much for inviting me in today for this webinar.
we welcome you very much. So, we are talking about the type of pneumonia that happens after this viral infection. And can you perhaps add to it that what is your observation when people get lung infection, lung involvement? Is that pneumonia more severe than the viral pneumonia, typical viral pneumonia?
Uh, I mean, what our observation so far is that definitely it gives a different picture than a standard pneumonia. Like typically they will come with a picture that I mean, they are getting short of breath and having persistent cough. And by the time they present in the hospital, the first observation we notice that their oxygen saturation is very low. And sometime they have added features of septicemia, but sometimes they may be otherwise well. But the peculiar thing is dysoxygenation or hypoxia. And so that is the difference from a typical pneumonia, where we do find that more often than not, they are more in septicemic picture. But in this one, sometimes they may be looking well, but when you put the oxygen probe on, their oxygen saturation is very low as sometime 84, but they will be looking normal to you. So that is very amazing kind of picture. And once, obviously, when you do the blood gases, you come to know that their PO2 is something around 5 or 6, and they may be acidotic as well because of hypoperfusion. And in addition, when you do the chest X-ray, you find out that they have got diffuse infiltrates, just like ARDS type picture.
So there is a sudden deterioration, which is rather atypical for a pneumonic involvement of lung. There is a gradual progression of pneumonia, but in this case, a person apparently looking well could be at risk of having an ARDS. So let's
Definitely,
see.
I mean, what we have observed,
Yeah, please go ahead. Please go ahead.
what we have observed in initially, we advise these patients to early prone position, which seems to improve their condition and their oxygenation. And you observe that improve in oxygenation almost instantaneously. And that improvement in oxygenation can last for anywhere between uh, 2 to 4 hours. But as obviously time goes on, that can change. So that improvement can last longer, or depending on how the pneumonia is progressing, that can vary. And we have to be careful and keep on observing these patients on regular basis, and make sure that we do not uh, obviously let them exhaust. And maybe if they are uh, looking exhausted, or there are any signs of septicemia, we may have to consider intubation early.
Now,
But there have been
talk,
variation in.
talking of management, I think we are extremely grateful to have two experienced anesthetists with a lot of kind of a background experience of ICU managing pneumonia patients. And this is going to help us, take us to the next section, where we are talking about the management of pneumonia caused by COVID-19. Before Dr. Hafiz, you came up, Dr. Taimur Mirza was taking us through different stages of involvement, and then we came on to ARDS. So when the lung is critically involved, you need to push oxygen into it. And that is where sometimes our training requires to be refurbished, that how inexperienced people who haven't done much intubations, for example, right now, even psychiatrists are called to do intubation because there are not many doctors available to help. So if Dr. Taimur, if you can guide us, if you can take us through your slides now, please, and share your thoughts through your slides. How do you propose the idea of ventilation? Please take us through.
Right. Okay, I have prepared a very small presentation. It talks about the basic ventilatory control so that every person whose specialty is not intensive care can understand it. So what are the indications of using the ventilator? So basically the ventilator is used in respiratory failure. So there are two types of respiratory failure, which we call it as type 1 respiratory failure, which is due to hypoxia. That means the patient is breathing, but the tissues are not being oxygenated. The oxygenation is not happening. The type 2 respiratory failure is when there is retention of carbon dioxide, whereas patient can be hypoxic or can be normal oxygen levels. So in these type of respiratory failures, the ventilation is, or invasive or non-invasive ventilation is indicated. The other indications of using the ventilator is obviously airway protection. For example, a patient who is got a low GCS, where the absolute airway is indicated, then we take hold of the airway, put the tube down, and put the patients on ventilation. Following cardiac arrest scenarios, we ventilate the patients. Then after prolonged surgery, we often require them 24 hours in the ICU on invasive ventilation. Similarly, after heart procedures, we need the patient to be on ventilation, and then we slowly wake them up and take this. Similarly, head injury patients, when we need to keep their carbon dioxide at low levels, we need to put them on ventilators. Next slide, please. Right, so there are two types of ventilation. One is non-invasive and one is invasive. So the non-invasive ventilation is called CPAP, BiPAP, or NIV. So NIV stands for non-invasive ventilation, basically. So CPAP is continuous positive airway pressure ventilation, which you can see a hood in this picture. This hood usually is indicated for the people who are infected with coronavirus, so that this hood contains the virus inside, and it's not it does not become an aerosol generating device. It restricts the. So basically, it can be done with the mask, tight fitting mask, but we prefer in coronavirus patients to have this hood on. It protects that. The other is BiPAP. BiPAP is actually combination of CPAP and pressure support. I'll explain what is pressure support in my further slides. Then once these measures fail, then we go on to invasive ventilation. Invasive ventilation is when you put the patient to sleep, you intubate the patients and put them on a ventilator and take them to the intensive care unit. Next slide, please. So on the right, you can see a picture of the ventilator. I will show you an original picture, but the important thing is when to intubate. So first thing is that you need to know the cause of respiratory failure. Whether you can remove the cause, you cannot remove the cause. So ascertain the cause of respiratory failure. If it is long-standing cause, for example, pneumonia, in this case, ARDS, then think about it and then tube the patient. Always keep in mind the outcome. Is the patient weanable? Because you cannot intubate a patient who is in fulminant cardiac failure, who has got a cardiac failure, who's got other comorbid conditions. Best is to avoid intubating that patient. So do not intubate every patient. It is a very critical decision. You have to make it with your colleagues and decide whether this patient is fit for intubation, whether you will be able to wean this patient off the ventilator, or you will end up in having tough decisions of withdrawing the treatment. So consider carefully the comorbidities. What comorbidities has it got? If it is heart failure already in place, then it's very difficult to put the tube in. You have to take the decision that this patient is not for ventilation. Similarly, other long-standing conditions can contribute. Look at the mobility of the patient, whether the patient is housebound, already wheelchair bound, or is not the quality of life is not good. Then in that case, you try to avoid intubating them. Now, in this present scenario, patients are coming with ARDS due to COVID-19. Now, you have to carefully assess the patients, their general condition, the conditions that I have stated up there. If they are not of that, then make a decision, careful decision, and put them to sleep. However, early, if you're thinking to intubate, then intubate early rather than they get tired and then they go off. So it's better to intubate them at early stage. It is highly recommended. Next slide, please. Right, so invasive ventilation. So there are two modes, which is pressure control mode and volume control mode. Now I'm going to explain you about the ventilatory settings and what modes do you have available. So one is pressure support mode. In this mode, the patient generates a negative pressure. That means patient is not paralyzed, but patient can take a little breath, and then the ventilator takes over and supports that breath. The second is pressure controlled ventilation. In this setting, you adjust the pressure of the ventilation, and it then controls the volume of the, you just control the pressure and the ventilator assesses the volume and gives the volume. So there is less element of or less risk of lung injury in this, because if you set the volume, you can set a higher volume, whereas the damaged lung cannot afford to have that volume. So in that case, the pressure control ventilation will be the best. Then CPAP and BiPAP. So you can control all these come under the pressure control modes, and these can be done once the patient is on invasive ventilation. The other mode is volume control mode. Here, you set the volume, and the ventilator gives you a set volume which you have set. For example, 500 mils or 600 mils you have set, and that the ventilator will give you that amount of volume. Similarly, volume control or VC, then intermittent mandatory ventilation is also called IMV. These are all volume controlled modes, or synchronized intermittent mandatory ventilation. I'm not going to go into details, but these are the modes that you can choose for your patients. Best would be to choose pressure control modes. Next slide. So what can you control on a ventilator? So on the left, you can control, on the left side, you can see tidal volume. So you can control the tidal volume by actually setting the tidal volume in volume control, or you can adjust the pressure, and the pressure will control the tidal volume. So it's up to you, but you can control on the things on which are present on the left side. Similarly, the respiratory rate. You can control the respiratory rate. For example, if you see on the blood gases, on arterial blood gases, that the patient is retaining carbon dioxide, so you can increase the respiratory rate to blow off the carbon dioxide. Similarly, flow rate, how much volume and with what speed you want the volume to go in. Then oxygenation. You can choose oxygenation. If the patient is hypoxic, obviously you will have to go up on oxygen. You can go up to 100% oxygen. That is, you have to open the full vent and the patient will be oxygenated at 100% oxygen, which, remember, which can be very harmful for the lungs. The lungs can take 100% oxygen, but after about 6 to 8 hours, the changes, the fibrotic changes start coming into progress into lungs. So avoid giving 100% oxygen to patients. Then work of breathing. So it's a tricky thing. Work of breathing can be taken over by the ventilator, or patient, when triggers a breath and during the weaning mode, then the work of breathing is done by the ventilator itself. So basically, once the patient is paralyzed, is sedated, then the work of breathing is taken over by the ventilator. Now look at the table on the right hand side. So combination of all these is called the mode of ventilation. So you can put the patients either on AC or assist control or CIMV, pressure control, pressure support, CPAP or PEEP. Now CPAP, as you previously saw the hood, the CPAP is called when the patient is non-invasive. And the PEEP is the same thing, that is the positive pressure ventilation to keep your alveoli open. So what happens is basically in ventilation, if you do not give the PEEP, you know, the alveoli in the lungs, the basic unit of the lung, it tends to collapse. So PEEP is a positive pressure, it's a continuous positive pressure air which is blown into the lungs to keep that basic unit open, so that it continuously takes part in the gas exchange. So PEEP is very important. Otherwise, the bases of the lungs or the lung or other parts of the lungs can develop atelectasis or become solid, and they then won't be able to take part in the gas exchange. And the last is SIMV, which is synchronized intermittent mandatory ventilation. We usually take up the patient when they come back from theater, that we put them on SIMV, or when the patients are paralyzed. Next slide. So lung compliance. Lung compliance is a very important part of the ventilation strategy that you're going to. What is lung compliance? Lung compliance, if you see in a balloon and you try to blow the balloon, the force that you use, or you feel the balloon, if the bigger the balloon, you're going to use less force, less pressure. So this is basically the compliance of the lungs. The compliance of the lung is basically change in volume divided by change in pressure. So the higher the compliance, the better it is. The low pressure it will be. I mean, it is inversely proportional to volume. So less pressure, bigger volume, good compliance. More pressure, low volume, and the compliance is very bad. That means the lungs are filled up with air, the lungs have got fibrosis in them, or patient has got pneumonia and a consolidated lung. The compliance will be very, very poor. In that case, it is indicative of maybe poor prognosis. Next slide. Right, the controls of ventilator. Now you can control on the ventilator the respiratory rate, the tidal volume. These two are usually used to control the CO2 and pH of the patient. So, and you can control yourself. You can increase, decrease the respiratory rate. You can increase the tidal volume, but you, at the same time, you have to be very, very careful. Don't give extraordinary tidal volumes to improve or to get rid of this CO2, because the lung is already injured. The lung is already damaged. So do not unnecessarily overinflate the lungs, because it's going to cause further damage rather than improvement. The other controls is the FiO2. So you can control your oxygenation supply from 100% down to 25 to 21% oxygen. And PEEP, as I explained earlier, why PEEP is important. On every ventilated patient, keep minimum 5 of PEEP. But in these patients where the alveoli are already filled with the inflammatory fluid, where the lungs are already fluid filled, you will need higher PEEP. And this is what is recommended in COVID patients, that you use at least 15 of PEEP. There were some centers who were using 20 to 25 of PEEP, but I think the new study which has come out indicates that don't go that up on PEEP, because that also damages the lungs. So the recommended is at least 15 of PEEP when the oxygenation, when the FiO2 is high. Keep your PEEP about 15. Do not. I mean, it's going to cause a drop in blood pressure because of venous stasis, but you have got measures to increase the venous flow. So do not be scared of increasing the PEEP. Please increase it to keep it to 15 in the initial days. Next slide, please. So if you can see, this is an original picture of ventilatory setting, which I have just taken from intensive care. If you can see, patient is on bi-level. Now this is Puriton Bennett, picture of Puriton Bennett ventilator, which we have got in our intensive care unit. It's one of the patients who is on bi-level. Bi-level is a mode of kind of CPAP combined with pressure support. So if patient initiates a breath, the ventilator will increase it. But at the moment, the patients are, if you can see the graph, there is no red mark in the graph. Red mark indicates the patient is taking his own breath. So there is no red mark. That means patient is paralyzed and not taking any of his own breaths. Now, if you see the frequency F on the extreme right where Sohail Bhai has put an arrow, you can see a figure of 28. So respiratory rate of 28 is set for this patient. 28 is very high respiratory rate. Next, if you come, there is a PEEP known as saying is 32. It is actually high PEEP, we call it. High PEEP is actually inspiratory pressure. So patient is requiring a very high pressure of 32. Normally, we don't expect this pressure inside the lungs. So that means the compliance is very poor. That means the lungs are either filled up with fluid, or the lungs have got a disease or pneumonia or whatever. That's why it's requiring very high pressure. The figure down is again a PEEP, but that's lower PEEP. That's the actual PEEP, which we call it extensor PEEP, which is provided from outside. So this is 15, which I just mentioned, that you have to keep the PEEP on 15. As you can see, the oxygenation is 70%. So patient is on 70% oxygen with a PEEP of 15 and inspiratory pressure of 32. So, and if you go on to the lower window is adjustable window. You can adjust the things on the lower window, and the top window is showing what you are getting out of the patient. So basically, we have set the pressure on the extreme left-hand side on 34. That is the set pressure, so that the ventilator does not cross 34, limit of 34. Then if you come the IE ratio, where Sohail Bhai has put the ratio, this is very important. If patient is hypoxic, you turn it down to 1:1, or you even inverse the ratio, that is inspiratory to expiratory ratio 2:1. That is inversing the ratio, that is if the patient is hypoxemic. But on the contrary, here the patients are not hypoxemic, but their patients are retaining CO2. So in that case, the inspiratory to expiratory ratio can be increased from 1:2 to 1:3 at times, so that to give enough time to blow out the CO2. But remember, if you increase the expiratory time, your inspiratory time will be reduced. So you are compromising actually a bit of a oxygenation. The next is that patient is giving you 28 breaths. Now look at the tidal volume. In spite of giving him a pressure of 32 of inspiratory pressure, the tidal volumes are only 363. If to a normal person you give, if you anesthetize a normal person, the 32 of inspiratory pressure can give you a tidal volume of around 600 to 700, all depending on the compliance of the lungs. So this window, the top window, is what you're getting out the results as of the what you have set in the lower window. So this is picture of an actual patient at this moment being ventilated in one of the ITUs. Next slide. I hope I'm not too fast.
No, it's fine.
So here is PEEP, which is called positive end expiratory pressure. This is nowadays, especially with Corona, COVID-19 patients, this is very important, because invariably the patients are requiring higher PEEP, and we are going up to 15. So why is PEEP important in ventilation? To keep alveoli open so that the gas exchange can continuously take place, to prevent atelectasis, which I just mentioned, and to prevent collapse of the basic lung unit, which is alveolus. G. Next. So now we come to the point which my senior colleague, Dr. Hafiz Rahman, was explaining how we manage the ARDS nowadays. So as he explained, that surprisingly, when the patient come to us, their X-ray shows a horrible picture. Dr. Sohail has mentioned that it is a white lung filled with fluid and ground glass appearance, with full of infiltrates. And patient, when you put on the saturation, they are saturating 70%, but they are very clear-minded. They are talking in full sentences. They are not tired. It is really surprising, because if the sats go down to 70, there's all sorts of risk, like getting an MI, getting confused, they get agitated. But surprisingly, these patients are very well behaved, talking to us. And if we do the arterial blood gases, the results come out with arterial pressure of only 6. Sorry, we are talking in terms of kilopascals, but I think in Pakistan we are using millimeters of mercury. So 6 kilopascals is equal to, I think, 50 millimeters of mercury roughly, or maybe less than that. So you can well imagine how these patients are. But so we ask them to prone, before deciding to put them on the ventilator, we ask them to prone themselves. It gives us some time to organize for intubation. Their oxygenation improves, because as there is a shift of fluid from the back area towards the and gets the more surface area for gas exchange, so the oxygenation improves. But I think we should not delay these patients. Early intubation and putting them on ventilator is highly recommended, because if we delay the patients, they get tired and the outcome is literally poor. So lung protective ventilation. Now, this is another very important. The lung is already damaged. So normally, what we give on a normal patient, if we are, ventilating a head injury patient or due to other problems, if lung is not affected, we normally keep 8 to 10 centimeters per kilogram of the body weight. But in these patients, we keep the lung pressures around 6, or volume around 6 mils per kilogram, 6 milliliters per kilogram. So around a 70 kilogram patient, we actually take out the mean body index, and then we take their volumes in consideration. So that comes out to be around 400 mils. So don't be scared that this lung volume is very low. It's not. It's going to protect your patient's lungs. So lung protective ventilation in ARDS patients in already injured lungs is very, very important. So keep your tidal volumes low. Then high PEEP, at least 10 to 15 centimeters of water is required. The other important bit is the management of fluids. These, we have to get rid of the fluids which has filled up the lungs. So how we do it, we tend to keep these patients into negative balance. How we do it, we don't give extra fluids, as in septic patients or as in other patients. We used to give quite a lot of fluids because what happens is in sepsis, the fluid leaks out of the capillaries and the patients are usually dry, and we keep them giving them fluids and filling them up to get the good blood pressure. But in these cases, fluids is not recommended. So dry the patient, as we call a term here, keep the patients crispy dry. And you can take help of diuretics. You can use furosemide to dry them up. The more you dry them up, the more the results are. But nowadays, again, there is a bit of a talk going on that overzealous dehydration is also not good, because they put the patients in the risk of acute kidney injury. So avoid that, but try to maintain the fluid balance in negative every day. Monitor those fluid levels. Then early proning is highly recommended, and not just one proning, because in regular non-corona patients, one proning or 2 pronings is sufficient. But I have myself seen, we have proned a patient 7 times in the ICU. One of them has showed good results. The other patients, minor patients, have shown not good results. So one of them has died, but others who we have done multiple pronings are showing good results. So multiple pronings and early proning. As soon as you see that the patient's oxygenation is more than 60%, I think it is indicated that you prone the patient. How long to prone the patients for? Usually the recommendation time is 18 hours. So you can keep the patient prone for about 18 hours, but be careful of the pressure points, especially the nose, the eyes. So you have to put some gel pads around the eyes so that it does not put pressures on the pressure areas. And after about 18 hours, just supine the patient and see the results. Then permissive hypercapnia. This is very difficult to get rid of the carbon dioxide from these patients. So we have got a permissive hypercapnia level of less than or about 8 kilopascals, which is about 60 millimeters of mercury. So your carbon dioxide can go up to 60 millimeters of mercury or 8 kilopascals. You cannot do anything about that. Don't do any overzealous measures, because otherwise you will compromise your oxygenation of the patient. So accept the CO2 levels of around 8 kilopascals or 60 millimeters of mercury. Similarly, keep your oxygenation level, arterial oxygen, less than or around 8 kilopascal. If the patient does not have any cardiac problems, keep the oxygenation or arterial blood gases about 8 or 60 millimeters of mercury, so that the FiO2, the oxygen that you are giving, comes down to 60, 50, 40%. So that will not harm your lungs. If you are overzealous and you are trying to achieve 10 kilopascals or about 80 or 90 or 100 millimeters of mercury, the arterial oxygenation, then your lungs will be at stake. Your lungs will get damaged from that high oxygen. So not to worry, we have seen quite a lot of patients. Dr. Rahman and we work together in one ICU, and we keep the patients on 8 kilopascals. Once they start improving, then you can increase the limit. And in spite of doing all this, the coronavirus mortality still stands from 50 to 60%. So you have to be very careful. Next slide, please. Right, this is a blood gas from original patient. So if you see, the pH is 7.2, PCO2 is 10, and PO2 is 9 point something. So in what is the abnormality in here? The abnormality is the increased CO2, and pH is quite acidotic. Normal pH levels are 7.35, but if you see here, it is 7.22. So let's go to see the base excess. So base excess right at the bottom, you can see is 1.9, and bicarbonate is nearly normal. So the clever people amongst you must have guessed that this patient has got respiratory acidosis. So this can easily be corrected by some ventilatory settings. So if we correct the the ventilatory settings, just fiddle with them, go in, just see what the respiratory rate is, look at the tidal volumes, don't increase the tidal volumes, but if you manage it, you can still blow off a bit of a CO2, but I'm sorry to say that this is the dilemma. Your patient can be well oxygenated, but getting rid of the CO2 is the original problem here, because the gas exchange is not taking place as it should have been taking place under normal conditions. So this type of blood gases you are going to face once you start getting the corona patients. Next slide. So this is my contribution.
So thank you, Dr. Taimur. I think it's a wonderful display of your not only experience, but I think it's a learning ground for anesthetists listening to you, and I'm sure this will take things a lot forward. I want to engage Dr. Hafizur Rahman through his very wide experience of managing respiratory failure patients in ICU. You mentioned early intubation. Dr. Hafiz, do you share the view with Dr. Taimur in this case?
Sure. I mean, obviously, we have obviously been managing these patients, and over the last sort of couple of weeks, and a couple of things I would like to add that Dr. Taimur has kindly mentioned, that be careful and about deciding which patient you put on ventilator, and it is very important that do not put obviously frail patients on the ventilator who normally you will not be able to get